Just small comment about the serology. Abdul, yes, we have to do the avidity test as indication for the current infection or past infection. There is also, you can do IgM. The major problem for IgM for tox is always false positive, because what we call it, there is some stuff we call it rheumatic fever, which is given a wrong identification for the IgM. There is a special lab that they do the IgM. They have to study the age of the cells and things, and then they will come with the final report whether it is really IgM, primary infection, or past infection. The other comment, this is a very good evidence for all the pathology and microbiology. When they went to the serology, to the histopathology, they saw the angle, the narrow angle. And then they almost said, okay, possibly it's Aspergillus. But when we go to the culture, it's completely different schema of the Cladosporium. The message here, don't take the final decision based on the histopathology, and know and who the culture is the gold standard. Thank you very much.
So always treat the patient, not the culture. Thank you so much, Dr. Qutb. We'll start with a very interesting case in relatively immunocompetent patients. So each ID physician can see a similar case. We'll introduce our fellow, Dr. Abdullah Alraddadi. He's an infectious disease fellow. Will present this case. Thank you, Abdullah.
Thank you, Dr. Rabah. So my patient is a 42-year-old female, presented with a fever for 4 days. She denied any GI respiratory, genitourinary symptoms. Systemic review was unremarkable. Past medical history significant for end-stage renal disease due to preeclampsia. She's on hemodialysis, dialyzing through right IgA permecat. She is under workup for renal transplant. Past surgical history only significant for 1 year, one cesarean section 10 years back. She presented to the hospital with a fever that persisted for 5 days with no localizing symptoms. On examination, temperature was 38, blood pressure was 130/60, respiratory rate was 18, oxygen saturation is 98 for room air, pulse was 70. Permecat line looks clean, no redness or erythema. Other examination was significant only for multiple small skin lesion on the lower limb. So she was admitted as a case of fever for investigation, suspecting CLABSI. Basic investigation included chest X-ray was unremarkable. She was started empirically on meropenem and vancomycin. However, the fever persisted. On day 4, blood culture gram variable Rhodes was identified 4 days later as NTM.
So now this patient has fever. There is no clear source except for the line, and the culture on the blood agar grew rapid grower, probably NTM. So the question to Dr. Abdel Fattah, are there any specific colonial morphologies that can differentiate from the blood agar the species of NTM, though it's not very usual to see the NTM from the blood in non-HIV patients?
Yes, it's very unusual to grow the NTM from the blood, of course, in the non-HIV. And no, for your question, no, you cannot differentiate just by looking at the colony and tell the species. You need to do a lot of testing. In the old days, we used to do a lot of subcultures on different dates, see, and put it in the dark and the light, and see how it's going to react to light, and so we can differentiate. Now we need to do the molecular much faster, but you cannot tell what species is it unless you do all this investigation, the biochemical, the growth, the reaction to light in the old days, and now we have to differentiate using molecular techniques.
Dr. Abdulrahman, thank you, Dr. Abdel Fattah. Do you think that we can know the species since it grew in the blood in non-HIV patients? It is a rapid grower. Can we estimate or know the species?
We know some by pattern and epidemiology, but I don't think it's easy to really identify it in an individual patient. And I think what I'm really interested in is how this was grown in a regular blood culture. Was it a regular blood culture or an AFP culture?
No, it was a regular blood culture. It was gram variable Rhodes. Then it was abnormal morphology, so they did it then in Kenyan strain. It was positive for acid fast. He did MTB PCR, it was negative.
In very rare cases, as you said, Prophet Rahman, usually you should use a specific media for culturing the mycobacteria from blood. But in very rare cases, some strains can grow in the blood culture because that you are injecting blood anyway in that bottle. So they make use of the uterus in the blood and the presence of the red cells to grow. So it's very, very rare, but it can happen that year. And sometimes that will confuse the microbiologist because the machine will flag it as positive. And when you do a regular gram stain, quick one, you will not see any organism. And you will be wondering why it's positive unless you really look for something very unusual in it.
طيب, Dr. Amani, what empirical treatment would you like to start in this patient? We don't know the species, the subspecies, and it is rapid grower NTM in the blood.
So typically when NTM grow less than 7 days, it's probably one of 3 species, Botulism, Cheloni, or abscesses, which is abscesses is usually a problem, usually tend to be multi-drug resistant. If I was going to use an empiric regimen, I would use probably imipenem or meropenem and clarithromycin and linezolid maybe.
Dr. Mohammed, would you like to add any
remove the
other
line.
regimen?
I remove the line.
Okay, yes, definitely.
Yeah, I think I would do it the same. I might add aminohydroxide.
Dr. Abdulrahman?
I missed if macrolide was included or not. Is it macrolide was?
Yes,
Yeah,
yes,
okay.
clarithromycin.
Yeah.
Yes, yes.
So what we did, we started the patient on azithromycin, amikacin, linezolid, and imipenem, and the Bermicat was removed immediately. However, the patient continued to grow microbacterial abscesses on the same for 10 days. Then we added tigacycline, and after 4 days from adding tigacycline, patient blood culture was negative. And the patient was kept for this regimen for 3 weeks.
Dr. Abdulrahman, do you have any question?
Comment that I really face sometimes with everyone, mainly resident fellows, requesting for repeat blood cultures. So we do repeat blood cultures at least 48 hours after the initial positive one, just to make sure that we cleared the blood. But in NTM, I really don't think we need to repeat blood culture as soon. So I am not surprised that it continued to grow in spite of broad antimicrobials that should work. And that may have generated anxiety and was not really necessary. And I'm sure if you have waited longer enough, even without tigacycline, you would have suppressed the growth.
What about the fever? The patient had persistent fever for almost like 10 to 15 days after this regimen.
It's still, I think the response for NTM should really be probably slower than a regular bacteria in terms of treatment. So I would have given the patient 5, 6, 7 days of fever is fine, as long as, because this is NTM. And they're not going to go in shock, they're not going to go to ICU. I will just deliver the antimicrobials, make sure that they have no side effects, and give them time to work.
Great, thank you.
So we kept the patient for 3 weeks on this regimen. However, in week 3, she developed sensory neural hearing loss from amikacin, was documented by audiology, and thrombocytopenia, severe thrombocytopenia is reaching 20 from linezolid. So linezolid and amikacin was stopped.
So patient improved significantly on the current regimen. However, the patient, as like usual, so Mycobacterium abscessus is a nightmare for any infectious disease. So she developed side effects because of amikacin and linezolid. After discontinuing this valuable medication, what do you think the alternative regimen, especially considering that it's sometimes difficult to have other medications like clofazimine and bedaquiline from other hospitals, and we don't have it usually in our hospital?
Yeah, again, so it's usually multi-drug resistant mycobacterium, and by this time we might have susceptibility that might help us. We don't have much of options. I think I would continue with the others. Imipenem was stopped, right?
Yes,
So I
no, imipenem, we continued
Was still-
imipenem.
So tigacycline.
We continued imipenem,
Yes. We continued.
imipenem, tigacycline, azithromycin, and we stopped amikacin and linezolid. So he's on 3 drug regimen now.
So I mean, we can continue tigecycline, azithromycin, and imibulin.
Okay. Dr. Abdulrahman, would you add anything or just keep the patient on the same regimen?
How much linezolid you've used? Because the current evidence for anti-mycobacterium activity now is actually going less and less with doses for linezolid. So if you were using 600 BID, I would probably have used 600 once daily. And even subsequently, after 2 weeks, you can actually space it to use it twice a week or so, the same dose. So that would be a really important agent. I think from even the first isolate, I would have made it very urgent to send the culture for susceptibility testing somewhere where it can be performed.
We sent it from the first day to my clinic, but it took sometimes. And she was on linezolid once daily 600. But
We tried actually, yes, based on this, our clinical pharmacist, he was excellent and he advised about linezolid once daily or an alternatively. However, the patient came back again with, now we'll continue.
so we added levofloxacin for the regimen since we don't have fluoxetine in our hospital.
The question now, patient has bacteremia without any clear source except for the line. Would you consider doing the pan-CT scan for each bacteremia? It's not common to see NTM bacteremia in the blood. Would you consider doing CT scan? pan-CT?
I think he had skin lesion earlier, right? So maybe he had another like deep-seated sources that we did not actually cover. So I would.
Dr. Amani, will you consider doing pan-CT?
Honestly, it didn't cross my mind. I thought it's line related.
Okay. Dr. Abdulrahman?
Probably do it for the chest only. I think it's important for the lung to have a lung parenchymal view. But I'm not sure I would need the abdomen and the pelvis, honestly.
Next slide.
4 weeks later, the patient came back with left breast pain with palpable mass. Examination showed palpable mass around 5 centimeters at the right upper part of the breast with erythematous skin. So we did CT chest at that time, showed new bilateral breast multiloculated enhancing fluid. The largest was 3.9 by 2 centimeter. We took aspirated from the fluid and again it grew acid-fast bacilla yielded mycobacterial abscesses later. Patient went for ultrasound guided drainage, was refusing total mastectomy. She was kept on the same medication. We ordered alternative medication in case of resistant or non-improvement. By week 6, the sensitivity came back. It was resistant to ciprofloxacin, resistant to linezolid, intermediate to imibulin. It's only sensitive to clofazimine, amikacin, and tigecycline.
What about levofloxacin? I'm sorry, I missed it.
They did not.
It
report
was resistant. We sent again levofloxacin, moxifloxacin, ciprofloxacin were all resistant. So what is now the regimen considering we don't have the clofazimine and we don't have access to bedaquiline?
I think I'm not really surprised for abscess to be this way. Unfortunately, clofazimine is very limited place. I think maybe the NIH or CDC has it as a stock as the only way to obtain it if you really need it. Tigecycline is a good one, and I would go probably with the highest dose and keep the others, at least the levoflox if it's doing some effect. Just keep in mind that the clinical correlation between the in vitro susceptibility for NTMs and the outcome is really very poor. So you would choose the best ones in terms of tolerance and keep them at least reactive, hopefully.
Will you consider continuing, Dr. Amani and Dr. Muhammad, continuing azithromycin despite the ERM gene positive? There are some evidence. So will you consider continuing azithromycin in this case? And this is real life cases with non-tuberculous mycobacterium abscesses.
The answer, I don't know.
Yeah, so I really don't know, but I think I would. I don't have much options here, so
Yeah.
whatever I can provide to the patient, especially that her situation is getting more and more complicated. So I will provide as much as I can. We always face this with the MDRs, where you give an antibiotic that you know it's resistant because you don't have options.
Dr. Abdulrahman, will you continue?
I think macrolide is really important, especially azithromycin, because with the clarithrol sometimes some of the strains would have an evolving gene resistance, but that's different than abscesses. I think I would keep at least 3 drugs. I would say tigecycline and levofloxacin and azithromycin. Azithromycin, if she has problems with that, can also do it 3 times a week. But I would really push her for what I would say non-medical treatments or non-antimicrobial direct treatment. I know this may not be really evidence-based, but we have seen these patients probably doing better if you give them more nutritional support, higher vitamin D levels, more exposure to sun, positive attitude, getting out and in the sun and so on. So I think we really have to play with, try to help her system to fight this with antimicrobials, because this is challenging, and these organisms are not easy to treat, and they will need at least a year or 2.
Yes. Next, thank you, Dr. Abdulrahman. Next slide.
So we offered the surgical intervention again, but the patient declined. We discharged the patient on clofazimine, bedaquiline, and tigecycline to be followed in the clinic after 2 weeks.
And that was after a while. We ordered the clofazimine, bedaquiline from everywhere because it was very ugly lesion. This is the lesion.
So unfortunately, in week 9, she came back. She was readmitted due to worsening of the left breast pain and the lesion. She was offered mastectomy again, but she totally refused the surgery. We did bilateral ultrasound. Left breast showed resistant multiloculated wall enhancement, not communicating with the rest of the lesion, but there is no lymph node. Right breast showed interval progression of multiloculated wall enhancement collection measured by 3.7 by 3.7. She was kept on the same medication. However, the breast lesion became worse, and we offered surgical interventions. She agreed on only left simple mastectomy with washout. We did left breast simple mastectomy, then right breast multiple ultrasound guided drainage. She was discharged home in the same medication, bedaquiline, clofazimine. We replaced tigecycline by minocycline. Unfortunately, now after 1.5 years of treatment, she still have multiple multiloculated collection at the right breast. We tried again intervention radiology drainage. There is pus, however, not collection could be successfully aspirated. We refer the patient to breast oncology clinic, but the patient deemed unfit for any surgical intervention due to her comorbidity. It's in her best interest to continue medical management and follow-up ultrasound. Now, the patient in our clinic, she has a donor for kidney transplant and asking for renal transplant.
Actually, this patient from P1, she has a donor and she wants to go for kidney transplant. So who will clear the patient for kidney transplant? Hands up. Who want to clear the patient for transplant? Only one? Okay. So how the Mycobacterium abscesses will affect the candidacy of the patient to go for a transplant? Dr. Amani?
Typically, when a patient has Mycobacterium abscesses in the lung, they decline the lung transplantation because of the post-surgical prophylaxis, post-surgical complication like abscess in the skin, fistulas, and so on. So we know that she has lesions in the lung, in the breast, she has uncontrolled infection. And usually, we always weigh the risk and benefit between the urgency and the need for the organ, for the transplantation per se, and the risk of disseminated infection in her case. I think with renal transplant, it's not as urgent. I don't think there's urgency in her case. I know that being on hemodialysis for a long time increases risk for mortality, but it's not like she is a candidate for lung or heart transplant that is very precious and needs to be transplanted. So I would not, honestly, I would not clear her.
Dr. Abdulrahman?
I would definitely not clear her.
Yeah.
And then in fact, I would have used this as a way to convince her to have surgical full debridement or even mastectomy for the lesions. because that's probably her only hope to eradicate the organism if she plans to get a transplant. And my question, do we have a subsequent culture from the sites that are still positive or negative?
No, negative.
So-
Only the first one was
So
positive.
subsequent cultures are negative.
Yes.
I think that really should really convince her to have a mastectomy and then a transplant, and later on she can have a reconstruction or something else, because with this bug she cannot be transplanted.
If she went for full surgical intervention, will you clear her for it? Because usually in the previous guideline, it was absolute contraindication to clear the patient for a transplant. Now there's a changes in the guideline and they are clearing some patients.
I think if we already managed to culture convert her tissue to negative, and we are managing to convince her to remove the remaining tissue, I would, yes, clear her maybe after another additional 4 or 6 months of treatment and nice healing of the site, and no more lesions by imaging of the breast tissue.
Do you suggest anything, Dr. Muhammad?
Yeah, so I totally agree that she's not a candidate for a transplant. I would also be hesitant to clear her even after having a treatment. I would treat for at least maybe a year and then reassess. Mycobacterium abscesses is really bad in terms of relapse and control.
Thank you so much. Next slide.
So this case demonstrates the fact that we all know mycobacterial abscess is really difficult to eradicate. However, there is a promising data that dual beta-lactam therapy could work against mycobacterial abscesses. This there is definitely in vitro activity, and this case was published last year in Infectious Disease Journal. It showed a combination of ceftaroline and imipenem resulted in successful clearance of sputum culture. Also, combination of bedaquiline clofazimine might have effect against mycobacterial abscesses. And the last slide, that this is a successful case of renal transplant in a boy who had BD mycobacterial abscesses, who treated medically and surgically, then was observed for 4 months, then they did the transplant, and even 2 years after the transplant, there is no recurrence of the mycobacterial abscesses. My take-home message is mycobacterial abscesses complex can present as disseminated bacteremia in patients with end-stage hair disease, and typically mycobacterial abscess multi-drug resistance, providing few antibiotic options with significant high side effect, like we said in our case, and managing mycobacterial abscess effectively necessitates both surgical and medical strategies. Thank you.
Thank you, Abdullah.
I think we'll move to case number 3. Very interesting, short case.
Okay.
You have
Go
a
ahead.
question? Dr. Hadil has a question.
For disseminated mycobacterium abscess to come in immunocompetent is kind of unusual. So it will be interesting to see her immunoglobulin level. Thank you.
Thank you.
Thank you so
Thank you.
much.
Can I add something about the
Yes.
sensitivity testing for mycobacteria, especially the non-TB mycobacteria is a very problematic bacteria in testing. Many of the NTMs will not have a guidelines for the cutoff values for sensitive and resistant CLSI and all the other reference methods. They just give you MICs and they just leave you for your interpretation for end of it. And so they're not always correlation between the in vivo and the in vitro sensitivity for the NTB. You will find a lot of discrimination. I'm glad you brought this 3 studies which showed that they can be successfully treated despite they are in vivo or in vitro resistant. One of the things also we know about mycobacteria specifically is they have a mixed population. The same infection will have some sensitive and resistant one. And with the advancement now in the sequencing, we knew now not all the species can, if you have a mixed population, the resistant might not be in the same bacilli. One bacilli can be resistant to rifampicin, and the other one will be resistant to INH, and vice versa between them. So if you, when using multiple antibiotics, you may treat the patient who are in vitro showing resistant because of the cross sensitivity between the other. And that brings also the debate, maybe Dr. Muhammad agrees with me. A long time ago, we were debating whether we should test the anti-TB and anti-NTMs individually or combine them together in one tube and see that they are sensitive. Okay, they are resistant to single antibiotic, but when you combine them, they are sensitive. That debate went along like in the 80s and 90s, but nobody's using it. But that brings it over again, whether we should test it in combination or in a single antibiotic. So this is just something to think about for the future.
Thank you, Dr. Abdel Fattah. Very informative.
اسمحوا
We
لي
have a
تغريده
question.
خارج سرب الاسئله ورقبه قبل ما يروح عبد الله. يعني he's the one who encouraged me. How many fellows, by the way, around? Fellows, hand up. The presence of Abdullah made me so happy because أنا قلبي دايم على الفلوس واعتقد إنه such an activity should be run mainly by the fellows. And the presence طبعا this activity one of the best, I must say. You have this experienced consultant and the young future consultant. I wish to see the fellows presenting the lectures, the updates, and the benefit of the consultant will come with the discussion and comments. And it's nice to have somebody like Abdurrahman Rakihi, قمة بالهذا ومقبل حديثي، علي العمراني، هذول الناس أفن عمرهم تعلموا خلاص. I don't want to see them lecturing. I want to see them, I wish, discussing, and the presenter are fellows. I really أشكر عبد الله وهنيه على الشجاعة هذه. I wish that وين مزار؟ وين مزار؟ Thank you. ودي اسمها إن شاء الله السنة الجاية المتحدثين أو المتحدثون يكون فلوس. طبعا فلوس تشمل الأولاد والبنات طبعا.
I think actually most of the work are done by the fellows. Thank you for them. Most of the work are done with the fellows. The cases are and the literature review. So Dr. Abdullah for the next case.
Thank you, doctors. I know it was a long day, but my next day is one of the most interesting case I have ever seen. I hope you agree by the end of the case. So this is a 50-year-old male patient with background of diabetes, hypertension, end-stage renal disease, admitted electively for living-related renal transplant. 3 weeks post-transplant, while in hospital, he started to complain of shortness of breath and dry cough for 2 days. Let's just take a step backward. Pre-transplant, quantiferon was non-reactive, CMV status donor positive, recipient positive. He underwent uneventful living-related renal transplant. Induction was by bezisterimab. Post-transplant course complicated by delayed graft function. Biopsy was obtained. He received ITG, pulse steroid for 5 days. Current immunosuppression is prednisolone 40 mg tapering dose, tacrolimus 3 mg BID, Cellcept 1 gram BID, and he is in prophylaxis, Bactrim, and valganciclovir. As I said, day 21 post-transplant, the complaint only dry cough and shortness of breath, no fever, nausea, vomiting. All systemic review was unremarkable, no sick contact, no animal contact, no travel history. He's married, lives in Medina, work as a teacher, has smoker and has 20 back year history. Examination, patient is afebrile, looks well, blood pressure 130/70, oxygen saturation is 98 on room air, respiratory rate is 18. Respiratory examination showed crackles over right upper lobe. Other examination was unremarkable. His investigation, significant for leukocytosis of 14, hemoglobin of 7, platelet 310, CRP 350, and procalcitonin is 1.7. Creatinine is 98, and this is his chest X-ray. Just for comparison, this is his chest X-ray upon admission. For better view, we order CT scan. Living related. So it showed right mass-like consolidations, big with central necrosis. I'm not sure it's obvious here or not. This is just a different view to demonstrate how big the infiltration is.
Thank you, Abdullah. So I'll start with Dr. Busaid. So this is like 3 weeks post-transplant in hospital with very minimal respiratory symptoms. Patients look well, and he has an impressive chest X-ray and CT findings. So the differential diagnosis at this point.
Well, it's unusual presentation that can be anything. It's too quick to develop that big. It's not clear if it is a mass or a collection, but I think infection is a possibility, but he's not febrile.
Yes.
I think biogenic will be one of the things that I will think of. Fungal, although it's too quick again to have this big fungal mass. The hospital-acquired infection is also a possibility. That's what I can think of as of now, but the rest is usually not this. Yeah.
So Dr. Amani?
Usually when a patient presents with symptoms suggestive of infection in the first month after transplant, it's either donor-derived infection or hospital-acquired infection. So the question from Dr. Raj is living related or disease or disease donor. He's living related. Usually they get screened very well pre-transplantation. So that's out of the, most likely it's not donor-derived infection. Hospital-acquired infection usually have this presentation is not typical. Usually bacterial infection or something like that. Not as far as his screening pre-transplant. He was quantiferon positive, negative, but patient on dialysis, they can have false negative quantiferon, but still for TB, unless he had TB pre-transplantation, it's very unlikely for TB to reactivate in the first month after transplant. It's almost impossible. It usually takes 6 to 8 weeks for someone to reactivate latent TB, unless, as I told you, he had something pre-transplant. Of invasive fungal infection, again, it's too big, it's too big, and it's not, again, not typical. Although they can have patient post-solid organ transplantation invasive fungal infection in the first month, unless this is a parasitic infection that I'm not familiar with, that is something else.
So, Prof. Abdurrahman, any further differential?
And I would be biased. He's dialysis, he's transplant, and he's a Saudi. And to me, that's TB until proven otherwise. Now, the growth of the lesion is really dramatic. And I'm sure he had a CT scan before the transplant, and that was clear lung parenchyma.
Yes, and he has chest X-ray on the admission. It was
Okay,
clear.
well, the chest X-ray may not pick it up, it was there before. But I think the other alternative diagnosis, the official diagnosis, would be nocardia. I think that's a possibility. He has received immunosuppression induction and also, I think, ATG, right?
Yeah.
Yes. So all of these and plus high dose steroids, all of these would really promote the growth of both tuberculosis and nocardia.
And nocardia, would it be like this big, like 3 weeks after transplant?
I haven't seen it, but I think it's possible with the degree of his immunosuppression if it was starting before and we could not pick it up for some reason. And then in the right timing, the right immunosuppression, it happened. I had no CNS symptoms.
No.
And no CNS imaging.
No.
Nocardia can also happen in end-stage renal disease patients, even before transplant. So like 20% of the time, nocardiosis happen in patients who have uncontrolled diabetes or end-stage renal disease. So we don't know what was happening before transplant.
We'll go to the next slide, please. Yes, sure.
So this is our differential. So
I know it is an infectious disease meeting, but I think in your differential diagnosis, you have to put non-infectious because it is also important. because this patient is severely immunocompromised, and so he had a mass, and this mass, I agree with Dr. Abdurrahman that it might be TB. But the one thing which can happen in this patient is malignancies. Malignancies, when the patient is given such immunosuppression, they can just grow out of proportion. So I'm just saying that in the differential diagnosis, you should put the malignancy.
Abdullah, can you put the CT back, please? Can we see the image again?
Yeah,
CT.
sure. Yes.
Now, hospital-acquired infection, as I mentioned, is completely out because the patient is very well clinically, and it will not be a hospital-acquired infection. So I would just say that you should consider malignancy as well.
I think also with mentioning nocardia, I would also add actinomycosis as one of the possible causes.
Okay, so I think we're going to go to the next slide, please. So I think, can we go to the differential, please? This is our differential as mentioned by the panelists. Okay. What would you start patient empirically? So we start with Dr. Amani.
Start treatment for HAP empirically, knowing that most likely it's not HAP, ask for bronch and take it from there.
And starting for bacterial, typical
Bacterial,
bacterial.
yes. Bacterial.
So the nephrotransplant team was very panicking when they see the CT, Dr. Abu Saeed, and they said, like, should we start antifungal, but please not ambisome? Would you start
Well,
antifungal?
It will all depend on how sick is the patient. So if the patient is stable, I think we can wait. If the patient started to deteriorate, even if it's not quick, but if he is starting to have more and more symptoms, started to be febrile, yeah, I might start empirical antifungal.
Prof. Abdurrahman, any more additions?
I always throw a question back. This CT was 2 days after the presentation, so 4 days of cough?
Yes,
Or?
yes.
Okay.
Actually, almost the same day.
Okay. If it's really only 2 days and it's only cough symptom-wise, I really don't think there's a rush to treat, honestly. I would investigate, including whatever they're planning with thoracic surgery or pulmonary, and I would hold the horses at this.
Okay, sure.
So we started empirically on antibacterial, meropenem, and mazolate. And we sent for microbiology, sputum culture respiratory gram stain negative, acid fast smear negative, MTB PCR negative, and we asked for pulmonary team for bronchoscopy. Bronchoscopy done, pulse cytology showed acute inflammation, acid fast smear and MTB PCR negative, and the culture later become negative, bacterial culture negative, fungal culture negative, and galactomanal is 0.12. Then we sent for multiplex PCR, which showed Legionella pneumophila.
So the question would be that, does Legionella explain the mass-like consolidation in the CT chest? To Dr. Abdurrahman?
أنا صراحة honestly ما شفناها قبل كده, and also we did not have multiplex before. I would not be too excited, honestly. I still would wait for other growths and cultures. I would treat for Legionella, but I don't think it fits to what we know about Legionella, honestly. And this is a multiplex, so again, it could be just an old DNA sitting there or whatever in the tube or in the bronchoscopy itself.
I think Legionella typically present with bilateral ground glass opacities or one of the differential of pulmonary nodule, small pulmonary nodule, not like this mass consolidation. So I wouldn't be excited too.
The same, Dr. Muhammad?
Yes, I agree. I would treat, but I will still investigate.
So Dr. Abdel Fattah, is there any possibility that this could be a wrong reading?
Yeah, I'm glad Dr. Abdurrahman said he's going to be very excited about multiplex PCR, because there is in our minds that PCR is 100% specific, 100% sensitive, which is not true. There's always false positive PCR. There's also what we call it a remnant DNAs or RNAs, especially when we talk about COVID, we thought that a positive PCR isolates the patient until he's negative, which turned out to be wrong, that they had clear. So it can be just a false positive PCR. As I said, clinically it does not fit, or probably there is a bacteria, but not the real cause of the disease.
Thank you. So
Okay. So our final diagnosis was Legionella pneumonia pneumonia. We suspected because all the other culture was negative. And we did actually, infection control, our great team did outbreak investigation to look for the source of the Legionella. And they did water environment testing, and they tackled the patient for 2 rooms in the renal transplant, room 1 and room 10, and they sent water culture from the sink and the shower in the both rooms, and the culture from the sink in room 1 tested positive for Legionella, and they found actually a biogram in the sink. So they did the maintenance, replaced the sink, checked the water temperature, blocked the room, checked the chloride level, and the only identifying source was stainless tin sink in room 1. After replacement, the repeated water culture for room 1 was negative. So assuming this is Legionella.
So I think we missed one slide. Actually, the histopathology from the biopsy, lung biopsy, there was only
Acute inflammation.
There was no fungal or TB. PCR was negative, and that was only the positive thing that we had, the Legionella. So going for the question, so because of that, after excluding other infectious etiology, it was diagnosed as Legionella pneumonia. So starting from Dr. Amani, how would you treat this patient?
I would choose azithromycin or levofloxacin for at least 14 to 21 days. Usually I would start with 14 and look at the improvement and maybe repeat imaging, because I'm still not very excited about the diagnosis.
Okay, so Dr. Musaid?
Just one question. So for the biopsy culture is also negative?
Negative.
Yeah.
Okay. So I think still this is not a typical presentation. I would treat, as Dr. Amani said, for probably 3 weeks, and then I will repeat the imaging to see how is the progression. And then also the patient clinical response.
So I think no one is still convinced that it's Legionella pneumonia. So, Prof. Abdulrahman? Yes.
Yeah.
This is typical transplant ID, I believe.
It's true. I think we have seen Legionella in immunocompetent people causing fever, shortness of breath. They are clearly knocked down. It's not an easy pneumonia to see. And here the patient has only cough. Maybe his immunosuppression has a relation to suppressing his symptoms too. I would treat at least 3 weeks and repeat the imaging at the end of 3 weeks before stopping treatment, and then go from there.
Sure, thank you.
The patient received treatment with doxycycline for total 4 weeks, and this is the follow-up chest X-ray showing complete resolution of the right mass.
So Abdullah, this was how long after the
We did not repeat it immediately. Because clinically the patient only have dry cough and shortness of breath and improved. Few months later, we did the chest X-ray, and this is the chest X-ray. So the duration of therapy, it's recommended in an immunocompetent patient to treat 7 to 10 days, immunocompromised patient 14 to 21 days. However, the duration of therapy is not well defined and depends on the clinical response. Legionella, the most common radiological finding of Legionella pneumonia are patchy unilobular or bilateral infiltration. However, mass-like radiological finding or nodules have been reported in immunocompromised hosts, particularly in patients with cancer. Most atypical presentation were reported due to Legionella non-hemophilia, not like our case. So the take-home message: Legionella can present as a lung mass nodule in immunocompromised patient. Early diagnosis is important for targeted therapy. We were very lucky that we had the PCR. I cannot imagine what will happen to the patient if we did not have the PCR. So this is just a message to use the diagnostic more and more. Although not frequently see, hospital-acquired Legionella can still occur, and there is a reported case in the literature warning outbreak investigations. Thank you.
Thank you, Abdullah. I think I'll just add one comment. I was like convinced actually that this could be Legionella after ruling out other infections, because this is the third patient to see with mass-like for me. Like this was the third. The second patient was actually from India, and he had a granuloma in the biopsy, and he had a Legionella. So we treated Legionella, and we were like about to start NTTB because the risk factors and then the ill-defined granuloma. But then after 3 weeks of therapy, the mass started to regress, which was very interesting. This patient, he had a QT prolongation, significant QT prolongation. Comments?
We cultured the environment for Legionella, but did we culture the biopsy itself for Legionella?
No.
Very interesting question. If we have a sample, would we send it for that culture?
Usually it's not routine to culture because these are very special media to grow them, the BCUIS media. And usually routine labs will not have the media. We rely on direct immunofluorescence or rapid antigen testing on Legionella. That should be better than the cultures because it's also very slow. Yeah, if the culture, if you have the facility to culture, they didn't. Yeah.
Very interesting cases, thank you. But again, going back to the diagnostics, in the old days, we would diagnose Legionella with urinary antigen, which is actually very sensitive and specific, and you wouldn't have this concern about is this a real PCR or not. And we used to use the Legionella culture plate as part of also respiratory workup. You already answered the question about that there wasn't a Legionella culture plate. Do you have access to urinary Legionella antigen?
Unfortunately, no.
That's a very specific test.
Long time to come back, and by that time the patient actually he had a follow-up X-ray earlier, which showed significant improvement. So at that point, he was continuing the therapy and discharged home in good condition.
Sorry, if I can only add, especially that you've identified a potential point source for an outbreak. The question is whether you've missed any others. Not everyone with Legionella presents with a pneumonia. So it's possible that you've had some patients with transient febrile illnesses in the same area, following times, that you could diagnose with the Legionella antigen, but you won't necessarily diagnose with a sophisticated test like a multiplex PCR on a BAL sample. You know?
Yeah, the problem is in hospital, it's hospital-acquired pneumonia. I think we did not think about Legionella to send to. It's not usual to think about Legionella in hospital-acquired pneumonia.
Yeah, I think the point that he had like the bronch done because Legionella wasn't at the top. We were concerned about other, including fungal anocardia. So he had the bronch done because the mass-like, there was concern of other unusual pathogen, especially with the sputum culture that was negative and immune status. The patient was heavily immunosuppressed. He had an ATG and pulse steroid. So the symptoms wasn't impressive, but we were concerned that because of his immune status, he wouldn't manifest fever and yeah. Thank you so much.
Thank you, Ghadir, for the interesting case. And now we'll be presenting also a very interesting case. With Dr. Samaher Al-Mutadaris. She's an infectious disease physician. We'll start with this presentation.
Assalamu alaikum. Hello, everyone. I'm very glad to see you, everyone, today. So I'm going to present today a very interesting case, and I'm happy to end the presentation by me. So here we're going to begin. So we have 65 years old who's CMV donor positive, recipient negative, living-related donor transplant on July 31 in 2017. past medical history of the patient, he had multiple history of rejection. Last one was on 2020. So just to go to the timeline of the patient, he had a history of CMV viremia on August 2018, followed by PGP infection on October 2018, followed by EPV, positive EPV-related PTLD disease on April 2020. So that's why the patient received 6 cycles of rituximab. Last one was on October 2020, and the follow-up, last follow-up for the patient PET scan on January of 2021 showed complete remission. So regarding medication, patient current medication, he was on Prograf, 1 milligram PID, sirolimus, prednisolone 5 milligram daily, and Ciptra. So patient presented to our clinic just for follow-up on September 2021 with history of intractable non-productive cough, shortness of breath, and low-grade fever. This was for 2 weeks duration associated with mild flank pain. Upon examination at the clinic, he was tachypnic with respiratory rate of 26 minutes per minute, desaturating on room air, reaching 84%, a bit tachycardic of 110, with acceptable blood pressure, and temperature was 37.9. Chest examination, there was bilateral inspiratory crepitation on both lung bases, and cardiovascular was acceptable. Abdominal, he had mild tenderness on the right upper quadrant. So due to high oxygen requirement of the patient, he was admitted to the hospital. He was initially admitted as a case of viral pneumonia versus atypical pneumonia. Basic investigation, including CBC, chest X-ray, full septic screen was sent for the patient. An empirical antibiotic was started on ceftriaxone, azithromycin, as well as corticosteroid due to desaturation. So this is the initial X-ray. As you can see, there's bilateral patchy infiltration. Initial labs came, the patient had mild leukopenia with WBCs of 2.5, neutrophil 1.5, hemoglobin of 9.8, with platelet of 90, ALT was 140, AST was 70, creatinine was 2.5, with urine analysis showed sterile pyuria, and culture came yeast. CRP was 27. Initial respiratory panel, including COVID antigen PCR, was negative. The tacrolimus level, along with sirolimus level, was within target. So on day 3 hospitalization, patient respiratory status kept getting worsening, required more oxygen and nasal flu, along with persistent mild abdominal pain. So ultrasound Doppler was decided for the patient and showed mild hydronephrosis. CT chest as well was decided, and this was the CT. Please. As we can see here, there is bilateral ground glass opacity, like honeycomb appearing with scatter nodule bilaterally.
So doctor, we'll start with Busaid. What do you think? This patient, renal transplant since 2017, she has everything. He had everything, PGP infection, CMV, PTLD, received the treatment, rejections. Since 2020, he had nothing, admitted now with 2 weeks of shortness of breath and desaturation.
Yeah, so the patient history is telling us that he is heavily immunocompromised for a reason or another, having all of these infections throughout the years. Would expect that he will have another opportunistic infection, given that the history for more than 2 weeks, bilateral infiltration. So community-acquired viral illness is one of the possibility. Talking about flu, COVID, I know the PCR is negative, but sometimes you might need deep samples, especially that the patient is not producing much of sputum. Also, I would think of other viral infections, CMV, adeno, and other opportunistic viral infection that might cause pneumonitis. So this will be on the top of the list. It's less likely to be bacterial unless it's atypical pneumonia with its causative agent, Legionella with its bacteria.
Yeah.
So this is what like crosses my mind. It's unlikely to be fungal or others.
Dr. Abdulrahman and Dr. Amani, would you like to add any? Dr. Abdulrahman?
Well, I would add, I think because of rituximab he received, I would add CMV, and I think very urgent BL is essential. Again, he could have acquired the new TB infection, which in someone with his state of immune compromise could present this way, including hypoxia. So these are the two things I would add.
So rituximab for PGP, you mean, and viral
For CMV also reactivation, because with rituximab usually we worry more about viral reactivations. I know he had EPV BTLD, so but I'm not sure we have even anything to do with that if we confirm it. But for CMV, I think we can help him with something.
Dr. Amani?
If I'm gonna bet my money, I would say maybe PCP. You know, how far was it between the last dose of rituximab and this presentation?
1 year.
So rituximab usually lasts for 6 months, and although it targets plasma cells and increases risk for viral infection, but there has been reported cases of PCP induced by rituximab. But I'm not sure about this now, since it has been almost 1 year after the last dose. The other thing, sirolimus-induced pulmonary toxicity can cause this presentation, and usually patients improve by steroids. And then I still think common is common. Bilateral gland infiltration, immune compromised or immune competent, probably viral pneumonia comes to mind, the first thing, or atypical pneumonia. Typical bacterial pneumonia, less likely.
So all of you suggested CMV pneumonitis. Do you think after 1 year?
I disagree.
Okay,
Sorry.
okay, yeah. So he's not, CMV, is it a very high risk in this population, in renal transplant after 5 years, rituximab after 1 year?
So CMV pneumonitis typically present in lung transplant recipients and hematopoietic stem cell transplant recipients. This patient, although far away from transplant 2017, but he, as Dr. Said mentioned, he is intensely immunosuppressed, especially with the treatment for PTLD. Maybe CMV pneumonitis, but I'm not sure.
So as you said, same differential diagnosis and in addition to sirolimus, possible sirolimus toxicity. Next slide.
So day 5, as the patient didn't improve, PL, as Dr. said, it was decided. So from the PAL, bronchoalveolar lavage, galactomannan came 0.7, culture was negative, respiratory panel was negative as well, TB workup negative from the PL, PGP, PCR was negative. So from the serum, galactomannan was negative, culture was negative as well. APB PCR quantitative was 640 copies, CMV PCR quantitative was 300 copies.
Will you change your differential diagnosis or the same? Are there any top differential diagnosis?
I think still we are thinking of shipping mutation.
Oh my God. How this work? Oh my God.
Yes, Dr. Boussaid.
So I think we still don't have an answer yet, but I would keep in mind community acquired viral infection. I might also treat for that empirically. It's not necessarily to have high viral load, although in lung we usually see if we have like pneumonitis, it's usually also afflicted with viremia. But I would treat and see in this case.
Okay. Next slide, Samahir. So far, the patient has CMV positive in the blood.
Yeah.
EBV positive, the quantitative 640. And since patient had like weird symptoms, we don't know who sent for parvovirus. It was not of from infectious disease.
And it
And-
was as well because the patient viral symptom PCV PCR was sent to the research lab, the PCR, and it came detectable. CMV was detectable as well, and these two was detectable, and EPV PCR was detectable as well due to previous PTLD for the patient.
So now we have 3 from the BAL detected because of the flank pain. We have sent because it was weird. There is no signs of bacterial UTI. We sent for VZV from the BAL. So it came back positive VZV, EBV, and CMV. So do you think now what is the top differential? How can we usually in herpes viruses
If
group?
it is from the BAL, it doesn't mean much.
Okay.
So it can be just a passenger that passing by, and I would go for biopsy.
Dr. Abdulrahman, do you have in your hospital, Dr. Abdulrahman and Dr. Amani, the quantitative PCR from the bronchoalveolar lavage?
Not sure they use it on BAL, but I think they would try. I'm not sure about inhibitors in our system. But I would, with the blood, I think the same kit can still apply for BL, but I really don't know whether it would work as an okay technique. I'm not sure.
The blood also came back positive for EBV. Actually, we sent for adenovirus, it was negative, which was surprising because usually also it is falsely positive. So it was positive from the blood again, EBV, CMV, and VZV, and parvovirus. So do you think we can, from the blood, if it's isolated from the blood, it will give us the diagnosis, or no, all the same in herpes viruses?
Like presence of ABV in the serum, as Dr. mentioned, it doesn't mean a lot, especially if it was very low. If it's in the 100,000 millions, I would be concerned. Same for CMV. But VZV, I'm not sure, but given this flank pain, did the patient develop rash after that?
Yes.
Because sometimes what we see is that patient present with intense abdominal pain, and after a couple of days, the rash appears.
Yes.
Yes.
And I'm not sure if VZV in the blood is like a CMV, they're all like herpes virus, CMV, HSV, and VZV. But the presence of ABV, CMV would not mean a lot to me. But VZV in the blood, I am not sure about the significance. Probably I would not consider it nothing. I would not consider it nothing.
Now the question to Dr. Abdul Fattah, this is very common scenario, especially in immunocompromised patients where we have patient admitted with respiratory symptoms and the cultures, viral, everything is negative. And definitely we can depend on the PCR from the bronchoalveolar lavage. Is there any more specific, even if it's less sensitive method to diagnose herpes viruses from the bronchoalveolar lavage?
Yeah, in the good old days, we used to use a immunofluorescence technique that we look for the virus inside the cells. When you do a lavage, there is a epithelial cells you carry on with the lavage, and we do direct immunofluorescence. If you detect the virus, that is a proof of local infection of the virus and local replication of the virus. So yes, it is less sensitive than PCR, but it's more specific, and the positive predictive value is much more higher than the PCR usually.
She also had transaminitis, correct?
Yes.
So usually with herpes viruses like HSV, CMV, EBV, if they're high, they might cause transaminitis as well. So probably one of them is a culprit, but not. I don't think EBV or CMV is high enough to cause this.
So
I don't know about PCV.
Well,
Dr. Abdulrahman, do you have any?
There are two things for me. I'm biased against in life. One is rituximab, and the second one is al-hilal. So I think even before I got the results from PCR, I would have probably empirically treated her for CMV until we sort out things out because of the severe hypoxia he's in. But I think the hepatitis and the other VZV findings are still important. The VZV, I think I would give it weight. That should not be expected in the blood.
Perfect. So let us go to the diagnosis. Everyone saw the diagnosis in the room. Next slide.
Sure. So as we said, we detected VZV from the blood. And we
So
just-
the final diagnosis patient developed rash
VZV.
after this pain. So the diagnosis was VZV pneumonitis along with cutaneous zoster and VZV viremia, because we didn't think like yet CMV PTLD is on the top differential diagnosis in this case because he had multiple complications before. But usually CMV pneumonitis probably will be associated with higher CMV level. And secondary, I will go with Dr. Abdulrahman and treat him empirically, but the patient has pancytopenia, elevated liver enzyme, high creatinine, which we did all the investigations for this patient. Next slide.
So this is just a study we wrote about rapid quantitative PCR assay for stimulating detection of herpes simplex and the herpes group in general. It was done by Engelman. They took a large sample, more than 22,000 sample of PCR from different parts. And the end result of the study was that the all herpes virus can cause asymptomatic viremia and replicated in the respiratory tract and blood, as we know, without causing active disease because it's DNA virus after all. But detection of VZV virus were associated with clinical symptoms. VZV virus more than 10 power of 3,003 was associated with high mortality and morbidity. And here, just to show you the sample number, the large sample number was EPV actually, but the more significant causing morbidity and mortality was VZV. So back to our patient, we minimized his immunosuppression and was admitted and took a cyclovir for 4 weeks. And actually the patient clinically significant improved and discharged home on stable condition. So just our take-home message that all herpes virus can be detected in bronchoalveolar lavage and in blood in immunocompromised patients without causing asymptomatic or active disease. CMV viral load more than 10 power of 3 in PAL might be clinical significant. Detection of VZV in blood always of clinical significant, and as higher load and higher number, the more morbidity. Replication doesn't mean active disease, and we need definitely more study